So this would be like a good Tony Buzan. We've kind of changed the environment a little bit. And then we'll perhaps take somebody and just kind of have a look at what the value of a lot of this stuff is. Now, you're going to get from me a rather simplified version, because that's how my mind works, of what we should be looking at here. I don't do major biomechanical analyses here. I kind of just sort of see, I'm a bit like Greg Grieve with the ribs, who says perhaps all you have to do is move them about a little bit. I've got a slightly bit, I would feel somewhat guilty about saying move them about a little bit. I would like to say I can perhaps distract them at the costotransverse joint or traction them at the costovertebral joint. But when it comes down to it, perhaps all I'm doing is moving them about a little bit. Okay? But in this area, what we've sort of seen is that stiffness is a kind of key feature of the dysfunction here, with some hypermobility, possibly in a segment or two higher than this area in the cervical spine. And that if we're going to protect this, we need to move this. Now, we know that when we come to looking at the cervicothoracic junction, say it's here, or here we've got the vertebra like this, that we can view this by a whole variety of ways, okay, which you've been doing. We can look at the effect of side flexion on the cervical spine and see whether we get rotation in query which direction, or whether we get it at all, which sort of signifies that this will not move into side flexion rotation. The trouble is that with all of these like specific level tests, if we go back and look at generalized stiffness, do they tell us very much to start with? Or in the ways that Grieve talks, perhaps we should be loosening this up a little bit. And then put our biomechanical analysis a bit later in the treatment regime, when we've kind of got things working somewhat. But if it's all stuck like this, is there very much point? I'm just asking you. I mean, I don't think there is. I'll come out with my thing of going into whether the arm comes up here and its side flexors to the same side. Because if somebody's stuck like this and the pectorals are tight, this so complicates what you find at the back, or stops it, that you're struggling to think, geez, is this moving? When actually it's a tight pectoralis major in front, perhaps. And so in all of these sort of individual tests, I still go back not so much to a biomechanical analysis of the shoulder girdle. I think that's good to put in later. And a biomechanical analysis of what happens when we move the arm. I think we've got to look at this a little more globally and start doing things to change all of the things that we find. And is it possible to say that, you know, that scalene is a primary thing, or that first rib is up and that's the primary thing, and all we've got to get it down and then everything else kind of moves around and corrects itself? I think just this gets very stiff and dysfunctional. And with the sympathetic nervous system, it has kind of more global effects, as Ossendorp talked about with dizziness, but how all of us talk about, you know, down to T4, the T3-4 syndrome with paresthesia in the arms and all this kind of stuff. And perhaps the individual analysis is something to leave a little bit later on, and that's how I do it. Now, what's your feelings in your own synthesis? Are you kind of doing a sort of very accurate biomechanical? That's fine if you feel that that's where you should go. I think sometimes you waste a lot of time with this, though, instead of just getting in there and moving them about somewhat. And this absolute specificity around here of looking at what happens is not so good. But I do think that there is some value in looking at the effect of the cervical spine on this area, certainly. Because if I do this and I get pain in the cervicothoracic junction, Is it because I've activated something below C4, C5, C6, like this, and sent referral pain down into the posterior primary ramus? Because you remember with Cloward's work, when he did the early anterior fusions of the spine, he found that with down to C7, and this sort of tends to refute some of the morphology, I must say, in terms of evolution, of the arms pulling out and the skin from this area going to the arms, so you've got a whole section in the cervical spine, that, or lower part of the cervical spine, where there's not continuous dermatomes. All right? But he found that you would get pain down as far as the lower part of the scapula with disc problems at C8. And so that we could get C6, C7, C8 causing posterior scapular pain. The thing that it usually doesn't cause is anterior rib pain. So if you get this and this, I think you're dealing with the cervical spine, the cervicothoracic junction. If you get it in the back by itself, I don't think you can guarantee that, and I think we have to do a few tests. Now, the one test that I have for this is sort of a real simple thing. Can I just get you out here a second? And then we can kind of talk about all these tests, because it's kind of nice. You've just done a thoracic course, so I'm kind of picking your brains on what Diane's teaching now, because I might have to review all my ideas again. Because I look at her as being one of our leading people, a really, really bright person. I was saying to Dad a little while back, you know, Dad, you drive me crazy. Here you are, you're running a clinic, and you've got 2 kids, and you run your 2 kids, and you write books, and then all I seem to be able to do is get through my day. Amazing, amazing. It drives me crazy when I look at you. Plus the fact you're developing all these new ideas. How do you do it? Well, I seem to have enough time. Can you take your top off, Deborah? Yeah, right. Well, if it is, I want some. I bought that book on smart drugs. All those special sort of things that are still possible. We can't get them in Canada, but you might be able to get them here at the health food stores. Okay, so if I were coming back into that sort of position there, and that caused pain into this area, I don't know whether it's the extension of the neck, or is it the extension as it arrives into this area that's causing the problem. So I have a kind of real simple little test. I simply say to Bob, can you just slump a little bit there? And is that okay? Yes, it is. Now I want you to keep that slump and just take your head back a little bit like that, so that we keep the thoracic spine in flexion. We don't allow it to go. Then I can say to Bob, how does that feel? No, she said, that still causes the problem. So I would be looking round about 6 or 7 for this. On the other hand, if she said, no, I can get right the way back there and it's not causing a problem, and then I say to her, now, one by one, I want you to include these vertebrae. Oh, that's the pain. And I would then sort of start looking a little bit more in detail at that particular segment as I go back.
How do you get her to recruit one by one down?
Just by putting my fingers on, putting my hand on the front and saying, bring this in. And I'm trying to sort of go back a little bit into an extended position. So if we come here, we've got this forward there. And then I say, and I can hold this now, bring this one in, bring this one in, bring this one in, like that, okay? So I can support the neck now and make sure that this is not being stressed further and further back, and then I can get to Barb to just bring this in, next one in, like that. And I think that's quite useful. If this movement causes the problem, like this, then what I would do would be the same test but slightly in reverse. I'd take the head into a slightly neutral position where there's no pain, and then I would ask her, by supporting the head like this to stop it going into more flexion, I would kind of ask her, can you take this forward? There. Can you take the next one forward? There. Can you take the next one forward? So we don't allow the neck to keep stressing the dorsiflexion here. And, you know, this is kind of very much up our alley to do this, because we know we can use this as mobilization, and so we can do these movements. And the flexion and extension is important. As far as if Barb, none of those hurt, but when she went into side flexion like this, it caused a problem. Okay? Is it because the side flexion has produced down into the upper thoracic, caused a difficulty there? Well, I could perhaps do a couple of things here, and we could sort of talk about this. I could ask her to keep the head still, drop the shoulder down on that side, which has now produced a right side flexion here, and then I could ask her still to do the left side flexion in the neck. So this is kind of locking up. Or I could use a non-congruent lock if I wanted to. I don't usually make it as complicated as this. I simply sort of try and put this into an opposite position there, and then come down here and see if it causes the problem. Or I would use rotation. We know that side bend and rotation go together throughout the whole of this segment, but that side bend is very much restricted in the thoracic spine by the existence of the ribs. So if that causes the problem, okay, I would then go into just doing a side bend movement down like this, and then I would ask her to rotate, and I would try and compare the difference between the side bend movement and the rotation movement here. And as I say, I can eliminate the other movement by putting this either in rotation or in side bend opposite. And I think this is a matter of just sort of experimenting a little bit and seeing if it's valuable. Now then, as far as all of the other things are concerned, I'm going to kind of do a little bit of a movement like this. I'm going to take hold of the pectorals and have a little look at this. I'm not trying to do any major analysis here. I'm just saying, geez, we've got 5 things we better get on with for the next 2 weeks, and then we'll do a more complicated analysis. I'll look at the first rib position here like this. If it's up on one side, is it being held up by the scalenes? Slight side tilt of the head, not too much, because I don't want to produce a rotation in the upper thoracic spine which creates a change in the first rib. So I take that down just a little bit and have a look if it's changed. If it hasn't changed, it probably needs to be mobilized. If it has changed, the scalenes need to be stretched. You know, when you're doing 45 a day, you haven't got time for fiddling around. You've got to sort of hit the right thing. And it's got its downside too. But you just, you know, some of these people just need to get working on, rather than a whole sort of set of analysis. As far as doing intervertebral joint motions, come and lay on your side there, Bob, with your head up this end. I would absolutely suggest that you have the arm over the end of the table for this, because if you don't, the first, second, third, and fourth ribs are all being held stuck by the bed, and they hold the vertebra stuck. So we just let this come around here, and I would make sure we don't have any rotation. I'm using all my principles of trying to make sure that my body and her body are totally in concert here, and then I can move back here and have a look at the extension movement with a little bit of a posterior shear because they go together. And I can see this stiffness in Bob. She definitely needs to be moved, and to over 3 or 4 levels. So perhaps kind of doing a careful analysis on all of those, they're all going to show up. But I know that they're stiff, and perhaps we just move them in every direction for a start off. So this is like heresy, isn't it? Then I can come around here and just produce a movement here. And in this position, I can rotate her and have a look at the rotational motion that's present there. I could roll her over and do it the other way, but I must say that I'm not so much interested in the absolute amount of rotation at this stage, just whether it goes on. So I could sort of come in and do it in this way. It's not exactly the same motion, I realize, but for an examination just to sort of say I've got to get going on rotation, it's probably adequate. Whereas if we're down to an individual joint and we're just trying to tidy everything up, then probably you'd have to do it in exactly the same way both sides. So side flexion, both ways like this, rotation, those are the things that I would look at in this particular area, and that's how I would conduct this examination. On very, very stiff ones that have lasted a time, this is what we're dealing with in this area. It's taken probably several years to sort of get like this. And so these motions of moving it around in a sort of semi-specific way probably are more accurate than trying to work it out individually, level by level, when everything's interfering with everything else. So let's just go about and just have a look at 1 or 2 movements in each of us and just see what the findings are. If it's making you very uncomfortable, what I'm saying, then you just keep on with what you did before. when we're doing this. But I would say that the biomechanical analysis is extremely important, but not right at the start when everything is stuck, because you're going to find abnormalities, and for me anyway, I kind of get absolutely squirrely trying to work out what it is that's going on. Whereas moving these seems to me to be very satisfactory in this way. And we've got some wonderful techniques, both mobilizing and manipulating, for this area.
David, can you go back just to your first rib thing?
Yes. Yeah, all I'm saying is that if I come and I sort of find C7, then I come just a little bit lateral, and we'll talk about the first rib and its attachments, and I'm sure Diane did this, but you know that if we look at the transverse process of T1, that the the costotransverse joint that belongs to the rib is on the anterior inferior surface of that rib, of that transverse process. So that any movement that we do has got to be ventral and caudal. And when we kind of get people that talk about the rib sort of being up here by about 3/4, of an inch or a centimetre, geez, there's got to be a lot of destruction has gone on there to allow a little tiny joint to displace itself by that amount. So I would simply look at this and see, is it a little bit up on one side? Just try to either come in front of the mass of the trapezius, or to just go from the transverse process of C7, just go below it onto the transverse process of T1, and then a little just marginally lateral and have a look at the rib. And this one on this side seems a little higher to me. So what I would do is I'd just very gently tilt the head like that. Now I obviously don't want to tilt the head too much to take all this strain off the scalenes, else we're going to get a side bend of the neck and this rib drops down. And it gives me the appearance that, it's the scalene relaxation, whereas in fact it's the side bend. To take the slack off the scalenes, all I've got to do is just a few degrees of side bend. We don't want it arriving lower down. Then I can have a look, and if it's still stuck up there, I know that it's probably not scalene tightness that's holding it, it's rib position, and I would move it. That would be part of one of my early primary maneuvers. Any other questions on this heretical approach to cervicothoracic dysfunction?
We didn't do first rib with Diane.
Oh, okay. Well, we'll be doing it anyway. We'll be doing it anyway.
For the side bending, you said you dropped one shoulder down, which creates right side. Drop the left shoulder down creates right side bending.
No, drop the right shoulder down. What would that do? Yeah, sorry, that's correct. Yeah, that's correct. Just drop that down like that. And then I could... No, I could come down like this and create left side bending in the neck in the presence of right side bending in the upper thoracic spine there.
Oh.
Okay, just to try and eliminate this. You could do it by the correct rotation too. That, we could use the congruent locking here of just putting it into the correct rotation, which would be rotating it this way, which would side bend it to the same side, and then I could ask her, can you just go down a little bit like that into left side bend? So we can kind of eliminate some of these. I mean, I'm not saying make them, incredibly sort of tremendously accurate or anything like this, but it does just eliminate, so that we know we've got to address this or we've got to address the cervical spine, because we don't want to be, even if we're doing these in a semi-specific way, we want to be semi-specifically mobilizing where there's a problem. But I mean, this is one of these areas that I think we could treat everybody in this group, even if you've had no problem, mobilize it about, and we'd all feel a lot better. It's like perhaps at the end of this course you'll feel that your neck's moving a little better without any soreness, even though you didn't feel you had a problem. What we'll do before we finish is everybody will manipulate me every level before I go back. With the exception of my thumb. We won't have the thumb done. Okay? Yeah. I had an interesting experience yesterday talking about instability. I kind of was not thinking. I've learned to sort of think not to put any weight on my thumb, and that since Barb made this, it feels so much better that I've kind of forgotten. But what I was doing was doing this, and I was sort of waiting. Somebody was doing something, and I was kind of just on my thumbs like this. Well, of course, here we are with that kind of movement there in the saddle joint springs this out, and it displaced itself. And I look at it and I think, geez, can't move it. And just did that, and it kind of repositioned itself, and now it felt good again. So here we are, an unstable joint that gets stuck or displaces at the end, and perhaps a little movement like that in that circumstance is, you know, kind of justified, but not to keep on doing it, but just to reposition it back into the normal thing. And perhaps a lot of these joints with the hypermobility, we know that this isn't going to be the treatment, but perhaps at that time, if it's stuck in an abnormal position, there's no point in trying to stabilize it in that abnormal position. We want to reposition it where it's good, which we can usually do with fairly gentle mobilizing, of course, not necessarily manipulating, and then do the stabilizing, if it's possible. Bob hasn't told me about whether I should be working some of my muscles here. I think probably, you know, here's a case, you think to yourself, is it possible to strengthen it like that? Probably the thing to do is to wear this and not to put myself in that position. That's probably the best thing. All right, so here we are. Let's just do one or two of these things, whichever ones you just want to practice. But I would certainly do the ones with the arm down, because we're going to be using these for mobilizing. If we've got a dysfunctional region, I think Olaf Evian's concept of treating this is correct. That we do semi-specific movements, which generally speaking mean congruent movements without trying to gain specificity in joints with your fingers. So you're just bringing in several joints into the movement in a congruent fashion. And perhaps we go from a congruent non-specific group of movements, and I don't mean generalized, I just mean that we're going over 3 or 4 levels, that we can probably go to more specific congruent movements merely by putting our fingers and making somebody work between an individual movement. And then of course we can become even more specific by using non-congruent locking and all this, and then we can go from that to manipulation. And probably that's the route to go. And the more generalized the problem, the more we're using semi-specific, non-congruent movements. And we know that as part of what we do, it's very important to utilize muscle, to use muscle stretching. But with manual therapy on this kind of course, we don't go into all the muscle stretching, albeit very important. What we do with the muscle is to look at some of the massage techniques that can be involved with coupled movement, which we're calling translatoric massage, just with the translation movements going on in the joint. And in this area, the translatoric movements that are so useful are these. I'm going to ask Anne to just put her hands in this position. It's probably a technique that I showed you last time. And I'm simply going to thread my arms through here like this and just do a little movement of just coming into extension, because generally speaking, dysfunction in this area is into flexion. They can't get back into extension. And so I can start to move now with a little massage movement of kneading and side bend and rotation. I come back up into the extended position by just pushing down a little bit more locally, as you see there. Now I don't want to get, I've chosen Anne because I thought she needed this anyway, but simply because she's got a low back problem, and we don't want to be getting a lot of low back movement. That's not what I'm trying to get. I'm trying to leave the low back and just work here in these upper areas. This is a technique taken from Hartman's book, who's a British osteopathic expert. And it's not from him only. This has been fairly common down the years. You see variations of this particular technique done, but it's a very, very useful technique to do.
How do you spell his name?
Hartman, H-A-T-M-A-N. Laurie Hartman. So that is the very useful translatoric movement. Now you remember yesterday we did some C7 work with stabilization of this area. I'd like to show you a technique now which stabilizes the cervical spine. Once again, a technique taken from British osteopathic literature, which is to bring the arm up into a position like that and let the hand of the patient go round the neck. Then I simply come round this side of the neck like this, and I hold and support. So she's supporting the neck and I'm supporting the neck. Now we can move down into the upper cervical spine using this as an extension rotation, and I can get all the right motions on here. Side bend rotation opposite. Coming into the correct pattern here. So this is a very useful technique, using that arm to facilitate some leverage into the upper thoracic. And when I ask Anne now to just remove her hand a little bit there and just take the head back, you can see the head's got a tremendous amount of movement that it could still do, and all that is safety for the neck. So by putting the hand there, I can really use this arm in a way of getting the congruent movements down in these joints with that extra leverage. This is a very, very useful technique. I'm just putting my hand, if I'm rotating, I'll be putting my thumb on the opposite side to stop the rotation. So just have a look with any of these things. Where do I put my thumb? I think, okay, if I have stiffness here, it'll want to rotate the next joint down, so I'll lock in the joint below by putting my hand on the opposite side, rather than kind of thinking individual, is it on the right or the left hand side. I think just work this out for yourself as you do this. The extension movement here, I can support the head. I know when we got it inside lying it was very good, but you know, this is quite a good position to do this in, because you can see how much I can leave her looking after her neck. I can actually come down fairly low here, and still she's got all that extra movement in the neck that she could do, which in fact is safety for the neck. So this is one of the very useful techniques that we've got, you know, swipe from the best with pride, and we did it because it's a useful technique to do. So those are two very, very useful techniques that we should just get in and practice, because now we're into doing the manipulative and the mobilizing techniques that are very useful. So just let's start to get the feel of what our patients are like by doing these two techniques. If I were to look at the single most important technique around here, I think that I would say that it was probably dorsal gliding. So that we are getting a little bit of a movement that's halfway between extension and some other strange movement. Because it is actually giving a gapping of the facets, and gapping of the facets is not like extension, which takes them down into a close pack. So it's kind of like a mixture between two techniques. However, with a loss of extension, this one tends to restore it. Can you just lay down, facing me, Chris, with your arm over the end. All right, so the one we used as a test, we can now do a little bit more deliberately, coming into this position here. And now as a technique, we can add to it rotations of side bend and rotation, which we wouldn't do when we were testing the movements, because we know that it interferes with what we feel. But this is how people move. So we would go into a whole procedure like this of the sagittal plane movement, and then bringing in the sagittal plane with the coupling. And this is a very, very useful group of techniques to do. And as I say, we've got usually many joint stiffness here, 3 or 4 joints involved, so that manipulation wouldn't be considered, because we're talking there about individual loss